Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
This is Dr. Candace Pierce with Elite Learning by Colibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Welcome to the IV Push Medication Safety podcast series, where I get to dive into the critical aspects of intravenous medication administration and how we can ensure patient safety. This topic really seems straightforward, and we often overlook the significance of what we are doing when we give medications intravenously. Before we decided on this topic for a podcast, I did spend some time reviewing medication errors, and what I found really highlighted that medication errors were IV medication administration in approximately 70% of cases, with about 26% of these errors classified as serious. And some of those common errors included administering the drug at the wrong rate, using wrong mixtures, or really combining incompatible drugs. And additionally, the Institute for Safe Medication Practices has identified numerous risks and has developed guidelines to standardize safe practices, indicating the widespread recognition and efforts to mitigate these errors. So data really indicates that medication errors related to IV administration, including IV push medications, really are a significant concern in healthcare. And the statistics of clinical errors really underline the critical need for stringent safety protocols and continuous education to minimize risk associated with IV push medication administration. And for this series, we're really going to go back to the basics a little bit. And joining me for this discussion is Loretta Dorn Arabello. Thank you, Loretta, for joining us for this podcast.
Thank you so much. I'm really looking forward to talking about this very important topic.
Absolutely. Can you share a little about yourself and your passion for this topic?
Sure. I have been working with different organizations and as an ICU nurse for a very long time with the practice of IV therapy. And of course, this became near and dear to my heart when I saw errors happening and decided I really wanted to be able to make a difference. And so I do have my master's in nursing. And in fact, my capstone project was evidence-based nursing for IV push therapy because I thought it was so very important.
Absolutely. And it really is when we start looking at medication errors and the statistics around them. So to really start the discussion, I wanted to kind of get into some historical background, if that's okay. So can you
Absolutely.
give us an overview of the history surrounding unsafe acts in IV push medication administration?
So just to maybe talk a little bit about why is this so important and what can
Yeah.
happen. So we know that in the U.S., at least 90% of all hospital patients have some type of IV therapy. So it's a really common procedure. However, with IV therapy in particular, with IV push medications, when they're administered, they have immediate bioavailability. Like once you put it in, you can't take it back out. In addition, there's really a very narrow therapeutic dose range. And of course, it's difficult to reverse the effects once the medication is given. And also, what I've noticed in being in a lot of different institutions and throughout different surveys that we've done, which we'll get into as we talk, there's a complete lack of standardization for the one process that a nurse does every single day that has no definite step-by-step standardization. So if you go into every hospital, you see one nurse doing an IV push, another one's going to be doing it completely different. And so it does become a bit a little hard to make sure, and I know you talked about it, that everybody is following the standards or following the same process. And it is a very dangerous potential adverse event. In fact, there's a lot of studies which have shown that, as you mentioned, that IV medications are associated with 54% of adverse drug reactions and IV drugs also with 56% of preventable adverse drug reactions. And so 56 or 59% of all the cases for adverse drug reactions usually occur during administration. And because of that, the ISMP, which is the Institute for Safe Medication Practices, actually started to look at this and say, okay, this is something that we really need to make a top concern for all of the healthcare facilities in this country.
And it's something that is so routine that we do so often during our day. I think, we do more IV push medications than typically we put in catheters. So to not have stringent evidence-based guidelines that, like we do for Foley catheters is
Correct.
very interesting to me.
Yes.
So since you've seen some of these um, unsafe acts as you were doing your dissertation, can you kind of give the statistics between when it started being looked at and did we see positive results once it was identified?
So, ISMP actually was the first organization that noticed a lot of adverse events
Mhm.
because people mandatorily report adverse events to them. And so they started to look at it and say, maybe we need to really understand a little bit better what's actually happening. So they actually did several surveys that were created to try to understand holistically what the problem was. So this goes back to, originally back in 2010, they did a
Mhm.
survey just to understand what was happening in the environment and the economic impact originally of medication safety. As a result, their first clue they learned was that nurses were using the Carpiject pre-filled syringes as vials. So they found this issue first. Once they
Mhm.
discovered that, they then conducted a holistic survey in 2014, which really revealed a lot of unnecessary dilution, and a lot of things happening like mislabeling or not labeling. How fast a drug is given is different across the board. So they did the survey, and then they decided that we needed to pull together a panel of experts. And in 2015, they pulled together a panel of experts to actually create the safe medication practices guidelines that were sent out. And from this, and in 2018, which is kind of interesting, they redid the survey, and of course, they found that even after putting these guidelines out, there wasn't a lot of follow up in terms of people uptaking the guidelines, and so that was
Mhm.
something they learned as well. And so, really, it started a movement to say, what can we do to get out there to talk about these guidelines so that they become more prominent in nursing actions? And so, of course, the Infusion Nurses Society, which writes the standard of practice for infusion therapy, they reviewed the standards as well that ISMP had put out, and they had incorporated into their guidelines or into their standard as well. And of course, the difference in a guideline and a standard is a guideline is suggested and based on expert understanding, and a standard is what we should all be adhering to for all IV therapy. So that would be a difference when I talk about infusion nurses standard versus the ISMP guidelines.
So I want to make sure everybody knows what ISMP stands for. That's the Institute for Safe Medication Practices. And so when we're looking at the history and kind of those key factors for unsafe practices, you really hit on that lack of standardization. But and when you were talking just now, what I heard was limited education. I'm thinking that maybe those protocols they didn't get out there, they were not educated on them, so I'm looking at limited education too. What are some of those other key factors that probably contribute to the prevalence of unsafe practices in the past and even still today?
Yep. For IV therapy, we could spend hours talking about this, but the first thing is that, and I realized this when I did my capstone as well, is a huge lack of training to start with in nursing schools.
Mhm.
Many schools will have if they're lucky, they get a week or 2 or 3 of basic theory, and maybe they get to practice, but most schools assume that once they get into the hospital, they'll be taught based on their policies and procedures. Um, and then the other thing too is, of course, during COVID, if you recall, there was a lot of times nurses couldn't even get into a clinical setting to even do their
Mhm.
clinicals, and so starting to see that effect as well. But in general, we did a survey, which is where our group that we created through CUSIM, which is a quality safety education for nurses, we realized that this was an issue across the board. And because two nurses in Arizona did a survey in 2019 of nursing schools, interestingly enough, every nursing school taught the students differently how to administer an IV push. So there was
Interesting.
no standardization for nursing schools either. And then once the student does reach the facility and they're given a lot instruction, that instruction many times comes from a preceptor who may not be aware of the standards either. Or if the nursing student has gotten some information around the standards, the preceptor will say, well, that's not the way that we do it around here. So
Mhm.
this is the
Mhm.
way that you're going to do it here. Um, and a lot of it, I think, is related to the fact that the policies and procedures even, and I know we'll get into this a bit more later too, aren't necessarily updated all the time, so that what the nurses are following may not be the standardized evidence-based practice either.
I
So
was going to go back to something you said at the very beginning of this was a lot of the schools think that the students are going to be taught based off of the facility that they're in. And yet it seems like the policies, procedures, guidelines, all of those things at each hospital are different. So it
right.
seems it can be very confusing to a student who goes to multiple facilities and they learn to do it this way, but then they go over here and they're told this is wrong. You got to do it this way.
Yeah. Yes, that is very confusing for students. And in particular, there's a lot of, as you know, not every preceptor has gone through formal preceptor training, and so you might
Right.
have a couple of preceptors as well. And even within your preceptors, they may tell you something completely different, which causes even more confusion. And
So
so
who's right
even
and who's wrong?
right, exactly. Yes. And I have noticed as well that in many institutions, they may not have a step by step process or procedure. It could be that there's an IV therapy procedure that just says order from the physician, carry out the order, use aseptic technique, and that's pretty much it. There's not a lot of good step by step procedures that tell you how to give an IV push. And of
Mhm.
course, that's why our group, through CUSIN, had created that step by step because we just didn't find one anywhere.
Well, and it also seems like medications that you give are also going to factor into how you give that IV push medication. Do you give it over 5 minutes? How much do you dilute it? Do you not dilute it? So not only do you have the guidelines, but now you have medications and you have to figure out the differences in what you give and how to give it.
Correct. And it's nurses have a hard time knowing where to go to for that information. And I will tell you that there's various resources for IV push administration, for individual drugs, for the time, for dilution, etc. With as many IV nursing books there are across the board, they actually say things a little bit different. The source of truth for each manufacturer is in their package insert. Unfortunately, nurses don't always have access to those package inserts. They tend to go to the automatic dispensing cabinet and get their once it's ordered, get their medication. And unless the institution has a source of information buried in their EMR, I'm sorry, or in their ADC, they
Mm.
don't always have the same information. And also, in terms of dilution, a lot of nurses are more likely to dilute a narcotic or a drug that is associated with stigmas than say like a heparin or a Lasix or other drugs like that. And I have heard many nurses say, well, I dilute that because I don't want the patient to experience a rush, or they may want the drug too much again, or lots of different myths that are untrue.
I've heard some of those.
Yes, and those are absolutely untrue. You're still delivering the same amount of drug. And a lot of manufacturers specifically state do not dilute. And that's one of the key tenets of the guidelines is to say, don't dilute unless the manufacturer states you should do that.
And
However,
that's also a medication error.
correct, it is a medication error. Just like if you pull a medication from a Carpiject vial, that's also off label and considered a medication error. You should be using the holder that comes with it. Unfortunately, a lot of institutions don't have the holder
Mhm.
available. And so the nurses just do whatever they need to do to get to the patient, which is typically what nurses do based on the resources that they have. And I've had nurses where they have them in the institutions and they'll ask me, "Oh, what is this holder you're talking to?" Like they're not even aware of needing to use it. So that's a big problem as well. Um, the the other thing too is with all of these drugs is the nurses will try to use a pre-filled syringe, which
Mhm.
is for saline. Using a pre-filled saline syringe for uh, for using to actually compound. I'm going to use the word compound. In other words, put the medication inside that syringe is
Right.
actually off label. Those pre-flush or pre-filled syringes for flush were never meant to be used to compound. In fact, that is also off label. I've had nurses ask me why. Well, the gradients on the syringe aren't meant to be exact. And
Mhm.
so you may or may not be getting the correct dilution if you're using it that way. So that is off label as well. But some institutions, not understanding this, will just have these flush syringes on the nurse's station or on the cart and not carry the saline vials that should be used if they do have to dilute. And many times I've seen where the nurses are having to go down to the material supply room to pull the vial, just a regular old saline vial, because it's not right there in front of them. So some of this is
Right.
related to having the supplies available in front of you to be able to compound. Plus, the other thing that nurses should not be doing is compounding more than 2 drugs in a syringe. That should only be done in the pharmacy also. And so if there's any medications that they're having to do that with, those should definitely come from the pharmacy.
Mhm.
La Labeling or not labeling, man, there's been a ton of I'm sure you've seen it in the literature, a ton of examples of injury from not labeling a syringe. I myself know of one where the nurse pulled up the syringe, left it on the counter. The next nurse assumed they knew what it was. They went to go give it to the baby, and the baby ended up stopping breathing because it was not what the nurse thought it was. Um, for it, again, a lot of examples, and I can read them,
Mhm.
but in this example, there was a 15-year-old boy with a history of malignant hyperthermia who received the contents of an unlabeled syringe that a surgeon thought was contained Marcaine, which is bupivacaine, with epi. The syringe actually contained straight epi, but the nurse had planned to add it to the saline bag, so she had just set it down unlabeled. It was given to the patient, which led to seizures and massive problems with this child, tachycardia, etc. So
Mhm.
if you're not labeling a syringe immediately, that's also a problem. So if you're pulling it out of a vial and you're not labeling it immediately, you also run into issues with giving the wrong drug to the wrong patient. And I've seen nurses in real practice pull two syringes out and then just say, "Well, I know which one is which based on how much volume is in there." Well, she puts it in her pocket, she or he. They go off, something happens, patients put their call light on, whatever. They go out, and do they remember which one is which? I don't know. So every syringe has to be labeled. which is why in the standards they call for the pre-filled um, medication syringes that are coming from the manufacturer that have the drug, the dose, everything like it needs to be delivered. So you use those syringes specifically, and it averts some of the harm related to the nurses compounding on their own on the floor.
I'm always so nervous too when I get medications in a syringe from the pharmacy because I didn't actively see what they pulled up. And I have to trust that what
Mhm,
they labeled and what they sent me is actually what it says it is. And
mhm.
so the thought of picking up a syringe that's not labeled, I just, that's interesting to me.
Yes, or putting it in your pocket.
Yes, yeah, and not remembering what it was, and you never know what you're gonna run into when you come out of that med room.
Correct.
Um,
Yes.
so my memory is not what it used to be these days. Pre-filled syringes, unnecessary dilution, poor medication labeling. What about when you have, IVs that are blocked or it's a little bit harder to push through? Um, that could also cause issues.
Well, obviously, if you've got an IV that's not working, your patient's not getting their drug. You
Mhm.
could potentially cause it to either extravasate if it's a drug that's harmful or at least infiltrate. So it's always important to check for, for patency of your line before you inject. Having said that, the one error that I see people or nurses do as well is you should always, when you're doing an IV push, even if you have a running saline line, which some patients do, you
Mhm.
should always stop your IV, push saline in at the lowest port or low injection site, give your medication at the rate it was supposed to be given, and not leave the room, not just go and do something else, not leave it at the patient's bedside, right?
Mhm.
Push all the
Mhm.
medication in at the rate it's supposed to be. Follow with a saline push at the rate that you gave the medication. Because if you put the medicine in, there's still going to be some medication in the dead space or the lower activated device or the little bit of tubing in the extension set. And if you bolus that next saline to flush it, you're going to bolus that medication. So you need to give the first cc or two of the medication at the same rate that you gave the medication you put in. And then once you do that, you restart your pump. I see too many nurses that use if you've ever seen a cassette pump, use
Mhm.
the upper cassette to try to push their medication in. Depending on the medication, the problem with that is it's such a low volume or a little volume that you don't know if there's anything in the tubing that may react with that drug. 2, if the pump goes off for whatever reason, and it takes a little while to get in the room, you don't know if the patient's gotten all the medication or not. If it's a drug that you're trying to look at potential side effects or how it worked for that patient, you may not know because you don't
Mhm.
know if it got into the patient. So the standard is always give the IV push closest to the patient. That is the standard.
So, how have standards for safe IV push medication administration really evolved over time? I know you talked about some of the early ones with the ISMP, but how have those standards, and are there other organizations that are involved with this?
Yeah, so again with the organization ISMP and then INS, and also there's some the as this PHQR, Patient Health Quality Network as well. They've
Mhm.
gotten involved. And again, it's mostly nursing pharmacy organizations that have really gotten involved. Typically, it's a nurse that gives it. There's been some discussion, well, maybe, pharmacy should get more involved as stakeholders in the nursing workflow, because one of the things that's so interesting is I do teach IV push and I teach a lot with ready to administer. And when the pharmacy buys ready to administer, from whatever company they're buying it from, many times they'll say, well, why would nurses need teaching? It's just a syringe. How hard can it be? But they don't understand workflow. They don't understand it is a new device. They don't understand it is standards. It is, understanding how to utilize this IV push method, because I found nurses that were so confused about how to use a pre-filled medication syringe. Even they were trying to either dilute it from a vial, or I had some that would actually try to take the because it's a lure activated device, so put it right up to the lure activated device. They were trying to put a needle into the top of it to try to dilute it because it's the only way they could get into it. So
Mhm.
it encouraged all kinds of very unsafe practices because they weren't using it like it should be used, which is in its form, the way it is, no need to dilute, etc. So I saw a little bit of that. So trying to get the pharmacy organizations as well to adhere to some of these practices or understand workflow was super important. Right now, a lot of the organizations that are really having an impact in this are, again, as I mentioned, ISMP, INS, and then, of course, some of the safety quality organizations also.
You've been mentioning the injectors, and I know for morphine is the one that I have always seen it with. And in all the hospitals I've worked in, um, I have never had an injector. We've always had to pull from the tube, and you actually have to know how to effectively pull from that tube. I've
Yep.
seen it. I've seen injectors twice. And each nurse was like, "Oh, no, no, this is mine. This is, keep it in their pocket, keep it hidden." But I do see that as an education issue. So the hospitals are buying these vials, and whoever's making these purchases doesn't realize, hey, you don't have the injectors or anything else that you need to actually effectively, for the nurse
Right.
to effectively be able to use what is being purchased. So it even seems like there's some education, not even just for nurses, but for the hospital administration of what is it that you're buying, and are you causing um, nurses to be put in a place where they have an error themselves, technically.
Correct. Yes, because they're just trying to do their best, get the drug to the patient using all the
Yes,
resources that they have, right? And
absolutely.
it's I've always said that nurses should be included in any product decision, what they call the P&T committees, depending on,
Mhm.
what organization. They should be included in some of these purchase decisions and be included then in the rollout of the new product so that they know how these products work. Um, and with pharmacists, they make all the many of the product decisions or material management without understanding that, hey, we do need a little bit of training. Maybe we should pull in our nurse educators to do these trainings. And having enough supplies. You mentioned the holders being in pockets because everybody is trying to keep it.
Right.
Obviously, it's because there's not enough supply.
Mhm. Absolutely. Yes. So can you walk us through the development process of evidence-based standards for IV push medication administration?
Sure. So let me go back and talk about how we ended up getting our publication and our information out to the public or to the nursing public. But the one thing that I think is kind of interesting when we started to look at this is we needed when we realized there was a huge gap. We looked at all the data. We realized that the last ISMP survey showed no change on a day-to-day basis. I was seeing all these things happening on the floor. I had spoken with the Arizona nurses at a nursing conference. We put our heads together and we said, we got to figure out how to fix this. So we pulled together some of the nurses from ISMP. We pulled together the education director at INS. We pulled together several nurses that had a interest in infusion therapy from very large teaching institutions, and we said, "What can we do?" So after brainstorming, we realized that the one of the best places to put a practice, we'll call it a practice standard, was QSEN, which is the Quality Safety Education for Nurses, because they really excel in putting together these step-by-step sort of criteria for training, teaching, and guidance.
Yeah.
We knew that the standard was already out there, the guideline was already out there, and so why isn't anybody using it, or why is there very little uptake? And so we it took us about a year and a half to pull this together, but we reviewed as a team all of the standards. We looked at publications, literature, etc. And then we did a survey before we even started. We surveyed every nursing school in this country because we said, well, let's start there. Let's start with nursing schools because we think this is super important, right?
Right.
And I believe we we surveyed. I'm trying to remember, but it was close to 375 nursing schools. We got lots of responses, and again, the responses were that, wow, it was so different across the board. Nobody was teaching exactly the same. And so we said, okay, we need to create standardization for nursing schools that can then pass on this checklist to these regular hospitals with their policies and procedures. So we worked on it for about a year. We actually came up with an entire checklist, and the checklist really covered, and I'm finding here, but it really covered all the different sections, including the new AANT infection control process. So there's a whole new process now for how you would create a way to decrease infections and IV push and IV therapy, et cetera. So we went through all these different processes, sections, put together not just the checklist, but why are you doing this? The evidence behind it. So from that checklist, we actually went to QSIN, and they said, yes, we love this. They made us make a few changes in it, obviously, for publication, but it was a peer-reviewed publication process, and we did get it published. After we had that published, we had we went to several conferences. We did a couple of podcasts. We went across the board to try to get more information out to the general public in places that they would see it. So a year later, we had also published an article in American Nurse Today because we think that's a really good publication for just general nursing knowledge. As you know, it can be expensive to join some of these organizations. It can be expensive to get the journals. And so we wanted to really get it out to as many people as we could. So this and by its way, it's open access on QSIM, but in this open access document, we again covered standard aseptic non-touch technique. We covered assessing the vascular access device for patency, which you've covered or discussed, the use of commercially available or pharmacy prepared pre-filled syringes, and then the only dilute when necessary, rights of a medication administration. And we went through, labeling and compounding. We put it in a way that an institution could take it and check their nurses off, do a skills check. Because that's one huge gap we notice is that institutions do not do a skills check with IV therapy.
No.
They do a skills check with everything else.
Right.
Why aren't they doing a skills check for IV therapy?
It's so routine. You do it so much.
Right. But this allows the institution to take this and use it to check off on, what's happening with the nurses, right?
Absolutely.
So from this, we got it published on the QSIN website. We got it published in the American Nurse Today, and there seemed to be more of an uptake this time, maybe because it was actionable. And we can talk about moving a standard to an action because sometimes it's a difficult translation. So this made it actionable. And from that, we then resurveyed the nursing schools. We even sent them the material directly in email to all of the leaders of the nursing schools. And to my great disappointment, we found the same thing that ISMP found after their repeat survey. We got comments like, oh, I forgot to look at it, or I haven't had time, or yeah, I've looked at it. I'm not sure, when we're going to be able to institute it. So we had a lot of people that just hadn't had the chance to look at it, touch it, put it into action. And there just seems to be a lot of barriers in implementing evidence-based practice, which I'm sure we'll get into, but it just seemed like there's a huge gap. In fact, I read an article and I went to a talk not too long ago that said that the average time from a new evidence-based information to implementation in practice is 17 years.
my gosh, that's crazy.
Yes.
I believe it though. I mean, but that's, wow. I don't even know what to say about that.
Yeah.
Oh my goodness. But let's talk about that some more in episode 2. So we're out of time for episode 1. I'm still flabbergasted by 17 years. Okay. To our listeners, thank you for joining Loretta and I for this first episode discussing IV push medication safety. Join us for episode 2, where we're going to keep talking about those 17 years, where we'll discuss the implementation of evidence-based standards, best practices, and continuous improvement to really help ensure IV push medication is done safely. So, Loretta, thank you so much for joining me for this discussion.
Thank you so much.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.